Guys, well, I've been given the unenviable task of going through all the data for FemPop disease in 10 minutes. So I'm going to go really fast, and hopefully they'll make my slides available as reference. But really, the point of the talk is to, let's see if I can get this to go forward, is to very quickly kind of just go over the endovascular interventional data for SFA therapies. And then there's a series of cases in the program that'll really illustrate a lot of the points. And I'll make a few editorial comments. For those who are, I'm an interventional cardiologist. For those that are interested, there will be an update of these guidelines from the American Heart and American College of Cardiology this coming year. So probably in 22, you'll see an update of the guidelines. Obviously, if you're a vascular surgeon, the SVS guidelines are also about the same vintage. So I expect there will be updates on these coming up. And for those interested in reading the literature, it's probably worth reading this document. Although old, it's still good with all the definitions that one might want to know. You're all already aware of all the medical therapies that are in the guidelines, so I'm not going to perseverate on that. If you take a board exam, the first answer is always medical therapy before you ever use a catheter or a scalpel. So I'm making the point to you here that when we're judged as interventionalists in our procedures, those who are claudicants, that's the angina of the legs for those of us idiot cardiologists. The outcome measure that's the most important is primary patency, because that is what we're judged by. There's no urgency necessarily to treat these patients, but when you're judged and when you're looking at all the trial data, the only thing that's consistently present in all the trials is patency. When it comes to the critical limb population or the limb-threatening ischemia population, the outcome measure that really matters both to the patient and payers is limb salvage. And so most of the data we're going to review are regarding patency because we're talking about stable claudicants. Obviously, everybody knows that for the claudicant population, when they have multi-level disease, the treatment is generally to treat inflow before outflow. And that is entirely because of the restenosis rates that are so high in the FemPop segment. The rates of restenosis at 1 year range from 10 to 15%, all the way up to 70% with plain old balloon angioplasty. And so if you have a choice, you'll treat inflow before outflow. But focusing on the SFA, again, the guidelines, this is again the American Heart Association guidelines, say that it's a class 2A level of evidence A to revasc if patients have lifestyle limiting claudication or inadequate response to guideline-directed medical therapy. The truth is this is the most common patient population that we all treat, and so you need to understand the indications and the best therapy. So a couple of appropriate use criteria that are worth reviewing because they go over the evidence for long-term patency. And so this is the most famous figure that everybody talks about in the SFA, and that's because the SFA is a torture chamber for any kind of endovascular device that's a permanent implant because of all the different stress-strain relationships. And so this is, for example, this is from Gary Ansel. This is a patient who's actually got a standard nitinol stent behind the knee at the adductor hiatus, and you can see basically, for lack of a better word, the stent is squished when the patient bends their leg. And that's why, if you have a metallic implant, the fracture rates are so high. So for the purposes of speaking the same language, there is a task classification, A through D. We no longer really think about this in terms of endo first versus surgical first, but it is useful as a descriptor of what kind of lesion segments you're dealing with. Most of us deal with, on a daily basis, task C and D lesions as a everyday occurrence. For comparison's sake, again, if we're comparing patency, surgical bypass patency that's in the literature for vein is about 75% at 5 years, and with PTFE it's about a coin flip between 40 and 50%. The first data for stenting versus balloon angioplasty heralded the era of stents with a disappointing restenosis rate still of about 37% at 1 year. You could get on the cover of the New England Journal when you could show that instead of 60% restenosis at 1 year, you could get down to 37%. Over the following decade or two, there's been many studies showing more or less this same figure. This is just to choose one standard laser cut nitinol stent, the Life stent, you can see that freedom from clinically driven TLR is about 75% at 3 years compared to patency, which is roughly half that. So if you were to draw a line to create a slope, angioplasty has a length to restenosis relationship that's linear and increases with length. The slope of that curve is flattened by adding nitinol stents, but there's still a significant length to restenosis relationship. So what has changed over the last decade? We have now interwoven stents, which is a new paradigm of bare metal stents. These have a clinically driven TLR rates less than 20% at 3 years. And I think the important take home of this figure is that after the first year, there's generally relatively little further reduction of patency over time. So if you can get through the first year, these people do pretty well. And here's an example of a bent knee lateral, similar to Gary Ansell's picture, but without the kinking that's present because of the Supera stent. The other big innovation is drug delivery. And in 4 minutes, I'll try to tell you everything I know about drug delivery. But basically, we have multiple modalities of treatment. The drug-coated stent is the Silver PTX. The drug-eluting stent currently available is the Eluvia. And the drug-coated balloons, which is the dominant player in the market, are all of the paclitaxel-coated DCBs currently approved. There really aren't too many eluting balloons other than those specially designed or in clinical trials for the insertion or instilling of drug and then a removal of the balloon. The bottom line is you need to have enough drug in the artery for long enough, usually 30 to 90 days, in order to reduce intimal hyperplasia. So it doesn't matter how you get the drug there, you just need to make sure it's there for long enough. So the typical DCB will give a bolus of drug, and then it'll decay relatively quickly. A typical DES has more sustained release, so you have sort of more controlled drug delivery for a longer period of time. Zilver, about 2/3 patency at 5 years. This was the first randomized comparative trial looking at a SFA stent against a bare metal comparator. This is still a significant benchmark. These lesions were simple, less than 7 centimeters, but it set the standard. We learned over time that just like in coronary disease, long lesions, small vessels, and the use of antiplatelet therapy is very important in these patients. Subsequently, the Eluvia stent has had head-to-head comparison to Zilver. It showed superiority at 1 year in terms of primary patency. At 2 years, I think this slide is hidden in the deck, there was not a significant improvement, although a trend for better patency with Eluvia compared to Zilver. And there's been multiple other data sets showing long lesions and complex lesions also do better with drug-eluting stents. Recently, just last week at the Viva meeting, they presented data in a randomized fashion comparing Eluvia to a variety of different bare metal stents in a 2-to-1 randomization scheme in 58 centers from Europe. What they showed compared to all of these bare metal stents, the Eluvia stent had superior primary patency at 1 year. So again, you can take it for what it is. This is more of a marketing study, in my opinion, than a scientific study. But there does seem to be a benefit to using drug delivery with stents. And here's their Kaplan-Meier curve at 1 year. What about drug-coated balloons? Well, the thing you have to recognize is that they're not all the same. Those that deliver more drug and have it stay in the tissue longer generally work better. So these are data from our lab at Cardiovascular Research Foundation showing that different drug-coated balloons have different amounts of drug deposition over time. This is borne out in clinical practice. The IMPACT DCB from Medtronic probably has the best long-term data. They have now 5-year data, which you'll hear about more, I think, during the course of the meeting, which shows that there's good patency. But notice that from 2 years to 3 years and subsequently down to 4 years, there is a relatively stepwise drop-off in patency over time. The advantage is you haven't put in an implant. The disadvantage is that there is probably going to be a regression of patency over time. When comparing drug-coated balloons one to another, it doesn't matter if they're a low or high dose. This was a comparison between Ranger from Boston and the IMPACT from Medtronic. It really just matters that you have enough drug in the artery for long enough. So this whole dosing controversy is not really a controversy. It's all about how the drug is delivered and how much is retained. And you can get excellent results with a variety of DCBs now. but the best data for 5 years are still currently with the Medtronic device. The other thing, when you're reading the literature, just recognize in all the registry studies, most of the long lesion registry studies have a very high bailout stent rate. I don't have a pointer, but in the last 3 bars on the right, you'll see that there's bailout stent rates of almost 50%. So they're not truly just drug-coated balloon data. They're also adjunctive stents as needed. So we have this menu of options for treatment of the SFA. How do you choose between these options? Well, there's a lot of comparative effectiveness data that's been distilled. The bottom line is that drug-eluting technologies have emerged as the best for patency, and patency is the variable by which you're measured for success in a claudican population. So both DCB and DES have probably the best data, and these are the devices that are probably first line for treatment if you're considering patency. If we go back to the paradigm that we said earlier of the length to restenosis relationship, the new innovative devices, vascular mimetic implants like Supera, some of the long covered stents, but especially the drug-eluting technologies, have all flattened the slope of length to restenosis and are probably the therapies that should be used as the mainstays of therapy. So for me, this is sort of an algorithm I made up in my head about how we treat patients. The overwhelming majority of patients in my practice are treated with drug-eluting technologies whenever it's feasible. You might notice that I don't talk about atherectomy much as a primary therapy. It's not a primary therapy. It's an adjunctive therapy to a definitive therapy, which is usually either an implant or a drug-coated device. And so I use atherectomy fairly aggressively for calcific lesions, less so for non-calcific lesions. That's just my personal practice. Just be cautious because there are profit motives to using other technologies. And so you have to be careful. Anything you use 100% of the time, unless there's solid data to support it, you can bet that somebody's going to be looking over your shoulder. So again, to hammer, the world looks like a nail. Most fempop disease, I think, is endovascular treatment. You probably heard about this controversy that erupted about now 4 years ago about drug-eluting devices potentially causing higher mortality. I'm going to summarize a lot of data in a couple of slides. Basically, this has been debunked in very large randomized data sets. And while the FDA has yet to withdraw their objection to drug-coated devices, they have all over the world. Japan, Europe, it's become a non-issue. So Voyager PAD showed in a large data set no difference in mortality between drug-coated and non-drug-coated devices. SwedePad in a randomized prospective fashion in Sweden showed the same, no hazard of mortality. And there's a host of other data sets that have shown the same thing. So I hope we got through the whirlwind in relatively close to on time. I would just summarize by saying there is a lot of data. There's even more data that's emerging. And increasingly in the next 2 or 3 years, there's going to be reanalysis of the codes for reimbursement. So whereas a lot of drug-eluting devices are not used in office-based labs currently, in fact, the penetration is about 1%. In the hospital setting where they are reimbursed, the penetration is 40 to 50%. The only thing that explains that difference is the profit motive. And so you have to be very cautious about how you use these devices. You have to also be, I think, very sanguine about the fact that the data show that they probably should be used in more of your cases than not. And if you're in a practice where you're not using it a lot, you have to ask yourself why, because somebody will be looking over your shoulder. So with that, I thank you for your attention.
Perfect. Thank you, Sahil. Beautiful.